Now, so what are we here for? Well, as you introduce myself firstly, I suppose. My name is Tony Ahmed, Nadeem Tony Ahmed, but middle name is Tony. Everyone calls me Tony. If you're local to the Midlands, you hopefully may or may not know me already. I've been around a lot. I'm a very old man. I've been in and around sort of NHS dentistry and still in NHS dentistry for nearly 30 years now. We've got our 30-year reunion this year, believe it or not. And yes, I'm sounding really old now, but I've got a 30-year reunion booked in about a week or so's time. So looking forward to that. The purpose of this presentation is to highlight what can be achieved by using the current regulations to treat higher needs patients without having to worry about whether you'll get paid enough or get enough UDAs. But at the same time, performers and providers should not fear seeing high needs patient. And I know it's one of those things, working practice, and I work in practice just the same as many of you might do as well. And is without having that sort of sinking feeling where you see somebody who needs a lot of work doing and say, oh, crikey, what am I going to do here? And it's just a way of perhaps guiding you through a methodology, a way of being able to treat high needs or vulnerable patients in a way that, one, is best for the patient, but also in a way that you can then obviously make it financially viable for yourselves as well. Now, I do talk a lot, and I've said that already, and I might go off on tangents. I'll try not to, but I probably will. So I'll try to keep to time, and I've already said I will leave some questions at the end. But I've got a fair bit to get to, and I'll try not to sort of drag it out too much. But the important bit, what I really want to try and do with this one is to try and give some worked examples. And we can, I've been on lots of courses where they talk about, do this, do that, whatever. But unless you actually sort of do the hands-on stuff, do the worked examples, it's hard then to sort of understand how you're going to implement something like this in practice. So the phase course of treatment, the avoidance of doubt phase course of treatment document, I think is a much underutilized way of generating UDAs and actually treating patients, fulfilling targets a little bit easier, at the same time providing and delivering better care. And I think, in my opinion, the right care that you were taught at university, and specifically aimed, as I said, for high needs or patients that may need more support, like sort of vulnerable groups. Now, I've mentioned a few objectives here. There are many more, and I've only mentioned a few here, but essentially the point of this is it's aimed specifically at high needs patients that need that additional support, that need that additional treatment to provide dental care for them. The purpose of it is, obviously, dentistry and NHS dentistry is a limited resource, and we want to try and use it efficiently as possible within the regulations. So staying within the current NHS regulations and using that avoidance of doubt document. Now, reducing oral health inequalities is a matter, personally, for me, of social justice and an ethical imperative for everyone, really, across the health sector. There are relative inequalities, and certainly in the prevalence. If you look at the data, look at a lot of data is around sort of dental caries in 5-year-olds, and it sort of increased between 2008 2019. There's lots of information out there, lots of data out there, and Dental Public Health and PHE do these surveys that show this, and also these inequalities in the availability and utilization of dental services across ages, sex, geographies, different social groups. There are inequalities in socio-economic position as well. Obviously, we're looking at areas of deprivation, where some of the most researched topics, and it is very clear and consistent, and there is plenty of evidence as well to show the prevalence of higher dental need, the impact of poorer health on patients and on the workforce. And there are barriers in the NHS at all levels, really, not just cost, but lack of availability of services, and perhaps services not commissioned correctly to meet local needs. And me personally, as an LDN chair, that's one of my, I think, one of my goals really, certainly in and around Shropshire and Staffordshire, to try and reduce some of these inequalities for the local population. Now, just a little bit of background, and really, why do I put this up? It's just to show all the different things, but the bit in the middle, the bit on red, is the important bit, and that's why I've highlighted it, and that's why it's important. And I think it was important given this talk, and we've been talking about phase course treatment for a long time because this document has been around for a while, but it hasn't really been utilized properly. And I think it does take someone working in practice and at the coalface to be able to show, because I remember I've been on a few of these courses, and I remember going on one at the dentistry show last year, and actually the presentation itself was fine, but until you actually show worked examples and actually using it in practice and to the best of your ability, it doesn't always come across very well to the audience. And rather than just being preached to, I think it's nice just to have some examples of how to utilize it. And I think what I'm trying to say is I'm a proper wet finger dentist working in a normal family dental high street. Nothing fancy, nothing special. And I see a lot of normal NHS patients. I do have an orthodontic contract, so I do see a number of orthodontic patients as well, but I have normal UDAs as well. And I think what it's demonstrating is, as dentists, we are, and I use this word a lot, entrepreneurs. I've been around the system long enough now, and I've been through a number of iterations of the NHS dental contract to know that there have been a number of systems, a number of contracts over the years, and actually as dentists, if you give us a system and give us a framework, we'll try and find a way to make it work. And we have ways of looking at contracts and the regulations and ensuring that at the same time providing a good level of care, but actually also with the current changes going on, it's actually utilizing some of those changes and some of those things that are allowed within the regulations to the best of our ability. Now, we talk about, what are the benefits? I think this is a no-brainer, really. You would think that some of this stuff is, you don't need to be told. But, streamlining planning allows dental professionals to work more efficiently, reducing stress and burnout. It also, I think anyway, facilitates better teamwork, coordination and communication between dental colleagues. And I think in summary, efficient dental treatment planning, certainly not just in the NHS, but just in general, benefits both us as as clinicians, but also patients as well, by ensuring that firstly, you're obviously looking after your patients, making sure that that they're happy and they're getting treated well, but also reducing those waiting times. I've already said it's a limited resource, and there are waiting lists for a lot of treatment, and certainly within NHS dentistry, if you're trying to see a patient and they need treatment, a lot of it, I certainly I'm booking sort of 4 to 6 weeks in advance, and it's being efficient with your time and managing your time appropriately, that you'll be able to, one, be cost effective, but also provide high quality care while optimizing that resource that you've got and promoting prevention. I think that's one of the big ones for me, really. It's all well and good, treating the disease afterwards, but I think prevention is one thing I think that's been left. And I think this is one of the things that I personally think really needs to be much, much more promoted. It contributes to, better, at the end of the day, oral health outcomes and patient satisfaction within the NHS, not just within the NHS, just within the population itself, and all the other patients within the system. And there are many barriers. And we talk about lots of these things. And this is a busy slide. And I could have put a few more on here as well. So let me tell you my history. Now, I'm a very old man. I've already said that already. I've been a dentist now for 30 years, and I know it's hard to believe, but it's true. When I first started out, I was taught to do what was in the best interest of the patient. You know, when I was at university, that's what they'd tell you. I think slowly with time, as you come out, and I think if you're younger members of the profession, so FDs and maybe 2 or 3 years qualified, you'll realize this, that working in the NHS, working with the rules and regulation that you got and the various iterations of the contract have made me change the way I treat my patients. And you change the way you treat patients according to what the regulations and the contract allows you to do. That's not necessarily always a good thing. Now, what I'm doing now is, I think, treating patients to fulfill my contract, not treating patients according to their needs. And I don't think that's right. Now, I've gone away from that, what I've been taught at university. And this is what I think the current dental contract does to you. But what I hope to do is show you that using some of the existing rules and regulations, using the avoidance of doubt phase course of treatment document, will enable you to treat patients how you were taught to do at university. It's going back to base principles, using what you taught at university and sticking to it. Now, we have been told that when we see a patient for an assessment, we have been led to believe that you should complete everything that a patient's needs in that one course of treatment, even though it is counterintuitive to what we've been taught. Now, the research that has come out, and we're talking about like the pilots and the prototypes that have been around, all the work that's been done around the pilots and the prototypes has taught us what we should already know, that we should follow the prescribed method of treating patients that is in their best interests. That's the stuff that you were taught at university, not what the dental contract allows, but what is in the best interest of the patient and what is best for them. And at the same time, if you do, use the regulations and contracts are available, you can make it work. And that's what I want to try and sort of demonstrate to you. Now, looking at the barriers to efficient dental treatment planning, you can look at the list there, and some of these things, things like the dental contract, these are things you cannot control. There's high patient demand. Yeah, we know there's too many patients. There are patients with complex treatment needs. I think there's been a bit of a fallout still from COVID, where patients weren't being seen. They weren't being seen for quite a long time. And as patients are now coming back, we're seeing that some of these patients actually do need quite a lot of work. They do need quite a lot of treatment, and some of it is quite complex treatment as well. One of the things that not mentioned here is and you may see this already, there are a lot of patients now going abroad and having quite complex treatment that then are coming back to the UK and having problems and expecting the NHS to pick up the tab. And that's a slightly different conversation. I know there's been some work being done by the Office of the CDO to try and look at producing some guidelines on how to treat these patients. But that is something just to be aware of, that there are these patients out there as well. Obviously, we talk about workforce shortages within the dental profession. We talk about paperwork, administration. Dentists in the NHS, yeah, absolutely. There is paperwork, there is admin work, there is processes, there's things you have to do, which do sometimes detract from patient care. And I've already mentioned about, prevention. I think, rather than just restoring everything, be much better for the NHS and the system as a whole to focus more on prevention rather than just restoring it. Shift towards preventive care would be much better. So what am I saying? What I'm saying is, you can only worry about the things you have that you can control. Don't worry about the things you can't. There are some things, no matter how you do, you can't help them. You cannot change the dental contract. Hopefully there are some guidelines coming and some changes coming nationally, but individuals as dental professionals, we cannot change the dental contract. We work within those regulations. Bureaucracy, yes, it is there. Record keeping is something that you just have to do. So do it. This is one of the joys of having automatic software dental management systems within dental practices. A lot of it can be done for you using templates that you then have to modify, of course. Makes your life a lot easier and simpler. You have systems and processes in place for treating patients and providing care. Then, of course, there are some patients, no matter how hard you try, just will not listen or change their behaviors. So concentrate on the ones that do. That doesn't mean you give up on them. At least try. But know when you're fighting a losing battle, concentrate your energies on those patients that are receptive. I do stress again, that does not mean that you give up on some patients, not at all. What I'm trying to say is there are some battles that you know you will never win. So you pick the battles wisely. Target your time and skills to reap the most rewards. At the end of the day, there are some patients, and I have those as well, who will only come and see me if they're having a problem. They'll only come and see me in an emergency. They're not interested in routine care. They only want to come and see you for that one problem. That's fine. And I have patients like that as well. So I do the best I can. That's it. One of the other issues, of course, is there is a lack of workforce. I know there's been work going in the background to try and help with the workforce, but again, that's something you have no control over. You do your best. You do the best you possibly can within the regulations and the environment that you're working in. And hopefully things with workforce, things like overseas dentists coming in more and more, and some of the changes to the regulations around getting overseas in, which have been relaxed. It is allowing more overseas dentists to come in, and that hopefully will have a benefit for the workforce in the future as well. I think one thing that I'll mention straight away is the elephant in the room, money. Now, we talk about this quite a lot, and I will talk about it as well. You can't shy away from the fact that money has to have an impact in running a dental practice. At the end of the day, most dental practices are small businesses, and we are subcontracted to the NHS to provide care. Yes, we want to provide the best care for our patients, but at the end of the day, if you can't make it pay, then NHS dentistry will disappear. And that's the last thing I want to happen. So I have a little Tonyism, and I've used this many times in lots of different lectures. So if you heard me talk before, you may have seen this already. It's one of my own. So get your dentistry right first, money will always follow. Now, it's a bit of a rewording of what is called Walson's law. So if you Google Walson's law, you'll understand what I'm talking about. And some of you might know this already, but essentially what it's saying is if you put information and intelligence first at all times, then money will just keep coming in. So essentially, if you try and do it the other way around, so if you aim for the money first, that's when you get yourself into trouble. What you want to try and do is do the best dentistry, provide the best service, look after your patients. If you do that, then money will follow. And that is, it's a hard one to understand sometimes, it's a hard one to accept sometimes as well. But you've got to think to yourself, what is it that you're trying to do here? What, as a dentist, what is it that you want to do? Do you want to just pay for your lifestyle? Or is it that you actually do want to make a difference and to improve the lives of your patients? Now, if it's the latter, fantastic. This is what it's all about. If you're just in it for the money, then go and find yourself another job. I personally think that, as a profession, we're here to serve the public. We're here to serve and provide care for our patients. And I think that has to be the overriding principle that we must abide by. Now, efficient dental treatment planning, there's lots of bits to this now. Now, I can talk about this quite a bit. There are so many different bits to it. Now, I'm treating this slightly separately at the moment to the avoidance of doubt phase course of treatment document. What I'm hoping is this sort of bit about efficient dental treatment planning is something, certainly as experienced dentists who have been around quite a long time, you should know this already. A lot of you should know this already. And I don't really want to be preaching to the choir here, in that you should know this already, but it's common sense. It's things you're being taught at university, you know. Begin by conducting a thorough comprehensive assessment, examination, including all the things you're supposed to do, radiographs, diagnostics, you know, if you're using x-rays, radiographs, whatever kind of special tests you want to do, collect as much data at the beginning as possible. Communication. This is something I think that's not really taught very well at universities. Being able to talk to your patient, these soft skills, these come with time, these come with practice. And the better you get at it, the much less likely you are ever to get a complaint. Because I think the vast majority of complaints, and I know there's some members on the group here who are listening, who are eminent members of the wider dental team here as well, who work within the complaints department as well, who will say this, that actually communication is one of the biggest things that is a result of complaints. That if you get your communication right and involve the patient in the decision-making process, you'll find a lot of this becomes much, much easier. And, you know, if the patient is comfortable, proposed treatment plan, how much they've got to pay, all that sort of stuff makes it much, much easier for you. Know your limits. You can't do everything. As an experienced dentist, you must be able to recognize the importance of assembling an interdisciplinary team around you. You know, there are certain things you can do, certain things you can't. So know when to refer. You know, we sometimes are guilty of what I call hero dentistry. You know, you see something and say, you know, I'm going to give it a go. I'm going to do I know I'm going to have a go at this. I'm going to do the best I can. Sometimes you just know that no matter how hard you try, you just don't have the skills or the experience or the materials even, or the training to be able to provide that, whatever that treatment might be. So know when to refer, know your limits. You do need to have a good team around you, the whole team approach, delivering dental care. I've been around a long time, and I'll say this one thing, that as time has gone on, using my wider team, so dental care professionals, receptionists, whether you have treatment coordinators, hygienists, therapists, dental nurses, helping you to deliver better care, it's a no-brainer. You know, having them trained, even things like radiographs, photographs, impression taking, will make you more efficient. It takes time away that you then can be treating patients, not doing other things. Common sense things like, you know, do the urgent stuff first, identify the most common pressing problems first, do those first. Clear, achievable, measurable treatment goals, you know, and ensure the patient's, you know, functional aesthetic most of the time. Develop a timeline. If you're going to phase a treatment, and we'll talk about this a little bit more, just make sure you communicate it clearly to the patient. Planning the order. Now, this is something I'll come to in a minute, but that will come with experience. And again, you know, do the prevention first. This is the bit I think we really fall down on. Do the prevention bit first, then do the treatment. So do the prevention first, then do the restorative stuff. It has to be in that way. We are, you know, always mindful. You know, we are guilty of this. You see somebody coming in, and you know they've got a broken down tooth. What do? You put a crown on it. But you don't think about resolving the diet and the oral health and the perio issues first. You sort the prevention out first. Prioritizing, you know, stabilizing the patient's oral health, having that, you know, 2-3 minute conversation about making sure you use your toothbrush, you know, changing your diet, fizzy drink, sugar intake, all that sort of stuff. Educate the patient. And I do spend quite a lot of time, and as I mentioned earlier, a lot of my work now is orthodontics, and some of the stuff I see is quite shocking. Some of the referrals that come in, I can't tell you. And I know there's been some really good work done by a local managed clinical network in Shropshire and in Staffordshire, a joint piece of work where they're looking at referrals and the levels of oral hygiene and caries on kids that are being referred in for orthodontic treatment. You know, there's no point sending someone in for braces if they've got 3 holes in their teeth, you know, if they're not brushing their teeth. Empower them to take an active role in their oral health. And then you've got to make some decisions about, you know, what kind of treatment modalities you're going to do. What is the most appropriate method for the patient? You know, absolutely talk about the costs. And if you're in the NHS, the costs are standardized, so it makes it a little bit easier. But if you're phasing treatment, then make sure the patients are aware that you're phasing the treatment. You know, make sure that at all stages, patients fully informed. They know what they're doing, risk benefits, all that sort of stuff. Again, having these templates, using software, dental software makes things a little bit easier because a lot of it is pre-done for you. And of course, records, talked about records, patient treatment, clinical records, radiographs, photographs, all this sort of stuff is essential for providing that continuity of care. So yes, we can do it. Efficiently treatment planning within the NHS for complex, multidisciplinary dental patients does involve careful management of available resources. Stick to NHS guidelines and have an open communication with the patient. Hopefully this is stuff that you should know already. I'm just going to, you know, just saying stuff that people should know already. And obviously providing that quality care while working within the constraints of the NHS. Efficient treatment planning for complex cases, yeah, it'll take time, it'll take practice, it'll take expertise. But as I'll show you with some cases, the more you do it, the better you get at it. It's not something that will come straight away. It will take time. Dentistry, it's very much, you can't get it out of a book. It's something you have to do. And the more you do it, the better you get at it. Having a team around you, that support around you, and sometimes some wiser, more mature people around you as well. Having that around you, that support makes all the difference. It's not rocket science. And I say again, go back to first principle, go back to what you were taught at university. Now, for some of us, that might be a long time ago. And I've said 30 years for me so far. And we have got into these bad habits. Think back what you've been taught and just do that. So I'm just going to go across into the actual document itself. So what are we talking about? When I say phase course of treatment, what am I talking about? Now, this is what I'm talking about. It's the phasing or staging of treatment has to be the best strategy to deliver better care. We have got into this mindset of seeing a patient and they just say, oh, no, everything has to be done in one course of treatment, you know, one band, one charge. We have to start getting away from that thought process. And that's specifically, obviously, for complex patients, that high needs patients that need a lot of care. And while it's considered to be a valid strategy for addressing, you know, multiple problems associated with new or high needs patients, phasing, I know, has been criticized privately by many dentists in the past for being used in order to maximize UDAs, a process we call gaming. Well, actually, that's not correct. This is not for everybody. This is for those high needs patients. You're not going to do it to everybody. Phasing should improve access to high quality NHS dentistry to meet the needs of those perhaps that not usually have access routine dental care in the past. Now, this cohort of patients will generally be those who are high needs and as such are more likely to be adults from perhaps vulnerable backgrounds, additional health or social needs. These are patients that, you know, we see from time to time. These are patients that perhaps, again, with the legacies of COVID that are coming back into the healthcare system who need a lot of work doing that has just been sat on. And they're coming into that process now where they just need looking after and they're really struggling. And it's a sort of like a perfect storm at the moment of lots and lots of patients need lots and lots of care. At the same time, I think the dental contract, and you know, I've said it already, and everyone will agree, all the way down to the Department of Health, and even the health minister himself has said the dental contract is not fit for purpose. It's not right, and it needs changing. And I do hope it does get done. And I think everybody, the BDA have said it, and I think most of the dental professional bodies have said this as well, that it does need change. But currently, we're using the system, we're using it to the best of our abilities and maximizing its potential. Now, the document itself, I mean, that's what it looks like, and it's dead easy to find. I put a little link there. Obviously, you won't be able to click onto it necessarily, or you might be able to, I'm not sure, but either way, you just Google it. So stick it into Google, type in, you know, phase courses of treatment, avoidance of doubt, and it will come up, and it's available online. Now, the document aims to support dental professionals and to clarify again where it might be appropriate to provide phased treatment spanning over several courses of treatment over a shortish period of time. And we must support and incentivize practices to provide care for high needs patients and set out within the aims and ambitions of contract reform. Oh, thank you for whoever's put that in, Thomas. I appreciate that. That's really kind. So someone's put a link in the chat there. So if anyone wants to see the actual document, there is a link in the chat now. So again, I come back to, you know, the recent contract changes that happened in November, just gone, you know, expanding the activity within band 2 to 3 categories is the start of the journey of how we make this happen. You know, enabling contractual support, enabling care of these patients. I think some of those changes have been, you know, very welcome and I think beneficial as well. The guiding principles are described within that document. Now, it was originally published in 2019, and it was recently 2021, updated. And the idea of it was to reflect the new periodontal guidelines that came out at the time. Now, I want to give clarity and you know, build some confidence on the use of the guidance as a legitimate and necessary good practice approach to disease management and stabilization for high needs patients, further strengthened and supported by the recent changes and the other changes that came around in skill mix delivery as well, where they're trying to promote more therapists and hygienists to become involved in delivery of care as well. And I think in doing so, the idea is to increase access for those high needs patients, reducing inequalities, enabling the best utility of the contract and the arrangements to support practitioners in delivering this care. Now, claims for multiple courses of treatments are acceptable, will be acceptable, where the clinical notes clearly state the rationale for the phased treatment for patients, medical or social needs, and supported with clinical evidence. However, the BSA data will continue to track, you know, UDAs and course of treatment claim per patient, and you know, you've seen the data. You've got your portal and the data that comes in through the portal that is provided by the NHS BSA. And yes, as dentists, we do worry. We'll look at it and say, you know, am I going to flag up? Am I going to be, you know, investigated? Am I going to be looked at a little bit more carefully if I start doing this? And I think what I want to try and say is, you know, look at the document. It does give you some worked examples in the document itself. Now, I will go through some myself as well, but within the document itself, it does give you some worked examples as well. And the idea of it is just to give you a framework, but also some support to say that if you can justify the treatment, if you can justify why you're doing things, there's absolutely no problem with that. And it's getting away from this mindset of just trying to do everything in one course of treatment, which, It's just not right for the patient. It's nothing to do with, and again, I go back to my original mantra. It's not just about generating UDAs, and I think that's not my point here. The point is, it's what's best for the patient. If you get a high needs patient in, you want to stage the treatment. You want to do it in little bits, and using the clinical notes and justifying it and using the correct rationale will back up any decisions that you make and justify any decisions that you make. So if anyone ever comes back at you in the future, you've got it all written down, no problem. And how are you going to phase it? Now, hopefully this is something, again, you might remember. This is what you were taught at university. It's not rocket science. Just recall what you were taught. Again, the order to follow when treatment planning, dead easy, right? Do the acute stuff first, then do the prevention. That's the bit everyone forgets. Do the prevention bit first, then do the stabilization. The stabilization, that's the, getting rid of the carriage, do some restorative. Then the definitive treatment, so that'll be things like crowns and bridges and dentures. And then, of course, maintenance. It's monitoring afterwards, just as important. Now, I'm not here to teach you all dentistry. You should know this and already be doing this on a daily basis when treating your patients. And again, it will depend on what level experience you are within our dental profession. Some of the newbies, the FDs and the 1 or 2, 3 years qualified may just be still sort of learning this and how to treat and plan. But some of us have been doing this a long time. This should not be difficult. The problem is that we have been programmed into that mindset that the whole course of treatment has to be concluded in one course. That's what needs to change. Phase it into smaller treatments, smaller chunks. It is in the best interest of the patients to do this too. You will always get that patient that wants to challenge you. And I'll give you an example. Only a week or 2 ago, I saw a patient, new patient, came to see me. Can I say with rampant perio, calculus everywhere, and not just told, but demanded that she wanted full set of veneers on her teeth. And we all know what we're talking about. We know they're called crowns. They are really crowns when they say veneers, because she's seen it on TikTok, and they're not veneers, they're crowns. And that the NHS should pay for it because it was affecting her mental health. Not to, disparage people with mental health issues, but trust me, there was no mental health issues here. The patient, FYI, was on universal credit. Now, I had to talk her down from this and explain that this was completely incorrect and that the information she had been given was false and not in her best interests. Now, it took time, but she got it eventually. But that kind of conversation takes courage, takes time to explain. That patient, though, then went on to have 4 phases of treatment, which resulted in a number of UDAs over a period of 12 months. But at the end of the day, the patient got good care, got a prevention in. The maintenance now is she's much, much better at looking after her teeth. The perio is under control. Hygiene is better. She doesn't have bad breath anymore, thank goodness. And it's the best outcome for you and the patient. A win-win. That's what we're looking for. We're looking for that win-win in every patient, in every treatment that we provide. But again, it comes back to it takes courage. You've got to have those conversations sometimes. Not for everybody, but you will get that challenging patient. I Googled somewhere that, I've been told this. I have a big sign in my surgery, and I put it on the TV screen in the waiting room as well, that my dental degree is worth more than your Google search. And I put that down. And it's a little bit tongue-in-cheek, but I put it there for a reason, because people think that just because they've read it on the internet, they've seen it on TikTok, they've seen it on Google, it must be true. And I've now become of a mindset now that if there's something on the internet, I always start off with the premise that it's a lie first until I can find evidence to prove that it's correct. Now, obviously, that's not true of all websites, and I point to the NHS website and certain other sort of professional bodies who provide some excellent information on the internet. But there are so many influencers out there, and we talk about social media now, not necessarily about sort of, websites themselves, but influencers who unfortunately are providing sort of very dodgy information to patients. And the number of things that we have to sort of talk our patients down to is getting worse and worse. Now, I've mentioned about, using this protocol is not for all patients. And it is really only aimed at those patients and the vulnerable and those that need a lot of, care and careful treatment. The importance of prevention, ensuring that, diet and oral hygiene are one of the first things that need to be addressed before moving on to more complex phase treatments. I think it is imperative that if you follow this protocol, you will need to keep good records. Absolutely. Clearly tabulating in your records that the treatment plans are going to be phased. Use the words phase, course of treatment. So it is clear to the likes of, regulators, inspectors, anyone else who's coming at you, that you are doing the right thing for that patient, that the practitioner is following a protocol and doing the best for the patient. Justification for the use of phase course treatment, absolutely, just in the notes. And again, you can use templates. There's lots of ways of doing it. Prevention is clearly better than a cure. And this protocol, I think, especially useful for practices who are actually, actively taking on new and high needs patients. So I know there are a number of, and certainly locally in the Midlands and Shropshire and Staffordshire, we've had redistribution of lots of UDAs, where we've had contracts being rebased or some of them handed back. And there may be practices taking on lots of new patients and high needs patients. Now, be mindful of the patient perspective as well, and the potential for a complaint to be raised, most likely by fee-paying patients who may become aggrieved at this. The high cost of, perhaps repeated Bantu treatments, when the background internet, again, information on Google suggests that one cause perspective as well, and the potential for a complaint to be raised, most likely by fee-paying patients who may become aggrieved at this. The high cost of, perhaps repeated Bantu treatments, when the background internet, again, information on Google suggests that one course, one patient, all you need. Of course, this is not true. And that is where you've got to have that conversation, have that communication with the patients, just to say that, no, this has to be phased. It is in the best interest of the patient to phase course of treatment. It is worth emphasizing that when you do an FP17 DC, it has to be written in plain English, mapping out the proposed journey. Put it on the FP17 DC that you hand to your patient as well. This is going to be a phased course of treatment. And that way, there cannot be any comeback. The need for a number of courses of treatment over a relatively short timescale means that, any subsequent complaint that might be raised will immediately be sort of shut down for, if it's recognized that it is part of the treatment plan for that patient. There are a number of complaints that do go through, and I mentioned this earlier, that, there are a number that go through for further consideration simply because either there's been poor communication or you can't produce the documentation, that's legible, understandable, that confirms the explanation consent has been established about phasing treatment. So get into the habit of writing on the notes and on the FP17 DC that you are phasing the course of treatment, and justify, what's the justification? High needs, high caries rate, poor diet, peria. These are all things you can use as justification. As you can see, document it, detailing the proposed treatment, make the patient aware that at each stage things might change. You may do the first bit and then see a patient and things have changed and you may have to change it again. So you can't have a detailed plan. You can't provide that at each course of treatment. That's just a given. But each course of treatment must have its FP17 DC, of course. Explain the charging system to the patient, gain their understanding that they know exactly what they're getting to. Again, this is not for everybody. This is not going to be for every single patient. This has to be a targeted approach to those high needs, those vulnerable patients. And why am I stressing that? Is because those are ones that you've seen it Number of times I've been on courses where you say, you see a patient that comes in that needs 10 fillings. Is it cheaper to give them 20 quid and say, go and see, the practice down the road? I propose that's not true. If you see a patient that needs 10 fillings, you just have to realize what's happened here. Treat the patient as a real person, as a human being, and actually provide them with the care they need, but you phase it. You put it in stages, and that way, one, you're providing the best care for the patient, but at the same time, you're making it worth your while doing it as well. Now, phase course of treatment. So, again, patient selection has to be paramount. This is, and I stress again, big capital letters, this is not a recipe for gaming. This protocol is not suitable for all patients. You have to pick and choose. But what it does do is provide the practitioner with a framework to be able to confidently provide high quality dental care for complex, high needs, vulnerable patients without being concerned that they're doing anything wrong. Because if you're doing the best treatment for that patient, how can it be wrong? You're doing the right thing for that patient. What you're doing is providing the right care to the right patient at the right time. This is what you should be doing anyway. This is what you were taught at university. This is all about being able to justify those actions. That's the important bit. It's having the record keeping so that if you ever challenge, you can legitimately say you did everything correctly. You're doing the right thing for the patient. Tell patients at the outset that they're going to have multiple courses of treatment and that there will be individual charges. That's fine. If they know this at the beginning, there's no problem. If you tell them halfway through, that's when it becomes a problem. Tell them at the beginning. Explain to them the reasons for this. It's in their best interest to stage long course of treatment because it will lead to a better long-term, more sustainable outcome for them. Also, before starting any long course of treatment, you ensure the prevention, the oral hygiene, the diet issue, these are addressed before going on for more complex treatment. Again, this is what you were taught at university. Go back to basics. I know what it's like when you see a patient walk in the door. They come in where their teeth are flapping, chronic perio, multiple carious lesion. Your heart sinks. Or I put it to you that this framework should give you that confidence to be able to deliver that care to the patients while at the same time making your hard work being remunerated appropriately. Isn't that all? Isn't that what we all want? Improving the care of our patients, going back to first principles, staging course of treatment. That bit I said right at the beginning: acute, prevention, stabilize, definitive treatment, and then maintenance. Now, this is what I alluded to earlier about NHS dental treatment. Now, I think it was November 2022, I think that's correct. But course of treatment, certainly for most complex treatment in the course anyway, they are banded, and they have been banded for many, many years. But the band 2 is a bit that changed. And essentially what it allowed is for treatment for multiple bits of treatment, and certainly root fillings, which is one of those things that almost died off within the NHS dental system, because they take time, they take effort, and unless you spend time doing it and do it properly, they are much, much less likely to be successful, and there's lots and lots of evidence for that. So the contract change came in, including more bands, and I think personally this is a great move by the Department of Health. It makes using the phased courses of treatment protocol much, much more attractive. Personally, I think it's a great move to support NHS dentistry as well. But I think there's more needs to change. The current dental contract, again come back to, not fit for purpose, everyone knows it, but using the current regulations, using what's available at the moment, can help you and make you provide the best care for your patients, as well as you being remunerated properly. And I think that banding of band 2, band 2A, 2B, 2C, I think that really was a step in the right direction. I think other things do need to change, but that certainly was a great move, I think. So how are we doing for time? I think we're not doing too badly at the moment. So we're perhaps about halfway through. Maybe a little more than that. So hopefully we'll try and finish. I'll try and do my best and stop talking so much and finish a few minutes early just for some questions. But one of the when I was asked to put on this lecture, one of the specifics asked was to use clinical examples from practice to demonstrate how this protocol can be used in the real world. I would beseech you all to go and read the document. It's only a few pages. It's not loads and loads. Use the link that's been provided in the chat. Go and read it. If you hopefully you know about it already. Hopefully some of you have read it already as well. Read it at your leisure. But again, until you start implementing it in the real world with real patients, with real cases, it's hard to understand how it can work. So what I've tried to do is I've been doing this for a while. So I've been using this in my work for, since it came out back in, say, 2019, during COVID at the time. And I'm trying to use it more and more. And certainly since the revision in 2021, where the additional guidance around how to use it within perio became available, I think it's really helped with some of my perio cases as well, because it's given me a framework, a justification to be able to provide multiple courses of perio treatment on patients. Now, you can all argue that all treatments actually are phased. All courses of treatment have to be monitored and maintained. We are just using, the current system of opening and closing courses of treatment and just sort of shutting them down. But that's just what the regulations are saying. But in fact, that's not true, because we have a regular list of patients that we see, and those patients we are monitoring over long periods of time. So any course of treatment that is closed will always need maintenance afterwards anyway. So lots of people argue that actually this is something we're doing already. We're phasing treatment because although we're opening and closing lots of courses of treatment, that's actually just one course of treatment for that patient. What this protocol enables is the ability to take on complex cases and see courses of treatment and open and close them perhaps in a shorter time frame. And again, aimed at high needs vulnerable patients that high street dentists, not specialists, should be able to see and treat to a high standard and not feel that they're going to lose out. So let's start with our first patient. So as you can see here, perio case. Now again, I look at this patient walked in. It's one of these where you can almost, unfortunately, you can sort of almost smell him before he comes in, because the bad breath was quite overpowering, even with a mask on. And when you see this kind of patient walk in, and I know a lot of GDP's heart sinks because they know how hard these cases can be in practice, and the outcomes are always a bit compromised, I think. But you can make this work and provide your patient with good care. So this patient, 35-year-old male, look how much bone loss there is. Heavy smoker, that was the issue. No particular medical history issues, not in any particular medication. He's a manual worker, worked on the roads as a contractor. Oral hygiene, lots of plaque. Works funny hours, a lot of them was nights. As you can see, BPEs, 4s and 3s really. Not many 3s, more 4s. Mobile teeth. If you look at, what am I looking at? Upper left 4. Not a lot holding that 4 in. A lot of bone loss. Relatively young man. Now, one of the revisions that came in to the phase course of treatment document in 2021 was this bit. Now, the British Society of Periodontology and Implant Dentistry produced this very helpful appendix to support the use of the avoidance of doubt phase course of treatment within perio. Now, it does go through in some detail what is expected at each stage of the patient visit and what can be claimed. And I think that's the important bit. It gives you a framework to hang your treatment, your course of treatment on. Now, if you're really keen, there is a YouTube video on the British Society of Periodontology channel. So if you just go into YouTube, type in British Society of Periodontology, the channel comes up. And one of the last videos they did, and it goes into some detail on how to utilize this particular protocol, phase course of treatment, on NHS patients to deliver care. Now, the actual video itself they put on YouTube is 1 hour, 41 minutes long, so be aware. But if you are into your perio treatments and enjoy doing perio treatments, and even if you don't, I think it's a good education on being able to treat perio cases successfully on the NHS in practice. Not talking about specialist care now. High street NHS dental practices should be able to deliver this sort of care. Now, if I just sort of zoom in a little bit, so this is the top half of that document, and just gives you a little bit more of a detailed view. Now, if you look through across there, you can see it actually talks you through each course of treatment and the payments involved. So look at step 1, first course of treatment, talking about education, behavior change. This is the conversation you're going to have with the patient. The risk factors, checking all the risk factors. And in this particular case, it's going to be smoking. That was the biggest one. But also lifestyle. This chap, he had very unsociable hours. He was doing a lot of nights. He wasn't looking after himself. He was overweight, heavy drinker, heavy smoker, all these sorts of things. And, you know, lots of flags coming up. This is the conversation that, you know, a lot of perio, and the more you know about perio, the more you talk to specialists in perio, the more courses you go on. A lot of it is lifestyle based. People have to almost change their lifestyle to improve their perio treatment because they're realizing more and more that actually your general health has an impact on gum health as well. And there's lots of studies on that, and I won't bore you with it, but people should know this already. They talk about cardiac issues. They talk about diabetes, being overweight, all being predisposing factors. And of course, you know, PMPR, that's the new word for scale and polish because people don't like me using scale and polish anymore. But professional mechanical plaque removal, PMPR, that's what it's all called these days, supra and subgingival. And if you do that in 2 appointments, that's a band 2 payment. Then you see them 3 months later, reevaluate. Is it an engaging or a non-engaging patient? What does that mean? Does it mean they've actually listened? Have they done what they're going to do? Non-engaging, go back and repeat it. It's a cycle. Do it again. Do a reassessment. Do that 2-stage. Again, you get a band 2 payment. And it is that cycle that you're going to go around until that patient becomes engaging. Now, obviously, you can't do it forever. And here in the protocol, it says have a couple of goes at it and then do a 3-month evaluation. If they're still non-engaging, it is at that point, then you just do what we call palliative care. So you're just doing what is in the best interest of the patient until at some point you do get patient engagement. So you're just doing the best you can for that patient. Now, if that patient then does become engaging, he's changed his ways, he's reduced his smoking, he's looking after himself better, his diet has improved, his oral hygiene has improved, his cleaning, doing all the things you want him to do. At that point, then you do the detailed pocket chart. That's when you do it. Then you do the subgingival PMPR 4 quadrants with or without local, however you want to do that. Again, band 2 payment. And then do that again in 3 months' time. Reassess, do it again. Now, if we go on to the bottom half there, you can see that the bottom half shows how the pathway can then cycle between those courses of treatment, but also how you move forward if the patient is engaging. So you go forward and actually eventually you get to that 4th course of treatment. And at that point, you've got to make a decision. Is the patient maintained? If they are, great. You provide that supportive care then. So every 3 months, every 6 months, however it might be at that point, you're looking after that patient, providing the best care possible. Or then you have to make a decision. If those pockets are not improving, if they're greater than 6 millimeters, then you refer on to more specialist care. And you will notice that if you try and refer a patient to the dental hospital, and most people here would refer NHS patients to the dental hospital, around here anyway, if you don't do this cycle, if you don't provide them with the evidence for this, they just get bounced back. But what I'm trying to show here is there is a framework here where you do these multiple courses of treatment, but there are payments, band 2 payments all the way down, that do make it worth your while to provide that care. It does give you that framework to be able to say, yes, I can do this. And you say to the patient right at the beginning, you're going to have multiple courses. We're going to make sure we're going to do our best, provide that extra level of care, extra scaling, super and subgingival, with or without local, whatever it might be. But if you get to that point where things are not improving, then that gives you that justification then to refer that patient to the dental hospital, because that's the first question they're going to ask you. If you don't provide them with that information, if you don't provide them with the fact you've done all these stages first, they're just going to bounce it back to you. And you know, if you've done due diligence, if you've done it correctly, there shouldn't be a reason why it does get bounced back. So what happened with this patient? So what actually went on? So what did I do? So this is what you want to know. What did I do? So patient came in initially, and yes, absolutely came in with a swelling, a gum swelling, gum infection. So initially I saw him, urgent band 1.2. Did some initial cleaning, antibiotics, mouthwash. He had quite a big sort of fat face when he come and see me on the top left-hand side, and provided him with some palliative care, as well as some cleaning as well, some subgingival cleaning around that area. And then got him booked back in for a proper assessment, did all the scoring, radiographs. He had an OPT, as you can see, and some other radiographs as well to look at bone levels, OHI, TBI, all the normal stuff. Really hit him hard with the smoking cessation. That's the important bit in this case. Talked about his lifestyle. Did the scaling, again, over 2 appointments, 3 UDAs. Next one, 3 months later, see him again. You reevaluate. The initial treatment is really just the patient to get him out of pain. After that, he was not in pain. There was no pain after that. This is just perio. So as you can see, there's no huge caries. There's no big holes. There's nothing in there that needed sort of urgent care. It was just the gum problem that was the main one. The issue here really is that he needed that initial care. Is he going to be non-engaging? Do you repeat the PMPR? So I spoke to him again and we reevaluated. Still wasn't quite there. You repeat the conversation. You talk about engaging, non-engaging, again, 2 appointments, carried on. There's a comment there about urgent band treatment cannot be seen immediately within 2 months. You're asking me a question about the regulations there. To be perfectly honest, I'm not quite sure what the rule is on that. As far as I'm aware, if it's a separate band, that is allowed, but I may be corrected by somebody else within the chat. So if someone wants to reply back to that, who might know more about how soon you can see a patient between urgent and initial assessment, I'm not sure. But as far as I'm aware, if it's a different band, that is allowable. But anyway, read the guidance. I'll say that back to you again. So what did I do next? 3 months, you repeat. At that point, that's when we did the detailed pocket charting, because he became engaging. He changed his ways. He'd realized that if he carried on this way, he was going to lose some of his teeth. Some of these teeth he's going to lose anyway, and you can certainly see some of the bone loss around some of these teeth is, that ain't coming back. Funnily enough, some of these wobbly teeth, and we talk about the lower left 6 and the upper left 5 specifically, started to tighten up at this point. They weren't nearly as mobile, and that's because he was starting to get some gum gingival reattachment back onto the teeth, and they're becoming much less obvious and much less noticeable. Evaluate the outcomes. Again, 2 appointments, 3 UDAs. And at this point then, at 3 months later again, you have to then look at it again, decide at this point what's going to happen. The outcome is you have to decide, is this engaging? Is this treatment working? Is the patient complying? Is this going to be a successful treatment or not? Not necessarily for everybody. And again, I say that to everybody. It may not everybody is going to work with perio. These are very complex cases with multiple sort of, predisposing factors. But what you have to decide at that point then, at the end of phase 4, is what you're going to do. Is that patient then going to be able to maintain on a treatment pathway, or are you then going to refer on to level 2 or 3 care? And it will depend on the pocket charting scores. And in this case, yes, I did. I referred on to the Birmingham Dental Hospital, and yes, accepted. And this is where I'm trying to say that if you do this, and I provided all the radiographs, so start and beginning radiographs, so I took some radiographs at the beginning and at the end, provide them with the pocket charting information that I'd done as well. And consequently, there's no reason why they wouldn't accept it. Yeah, absolutely accepted. He's in treatment. He's had a number of courses of treatment at the dental hospital. But I want to say there is the total treatment time from start to finish was around about 12 months. And the UDAs there, 13.2, and I've given a guesstimate there of about 29. Now, £29, that's just a local average. So this is the average sort of UDA value that some dental practices will be a bit more, some a bit less, but that gives you an idea of the amount of money you will generate. There's a question in the chat: are you not supposed to do 6 point during the first visit? Well, if you look at the periodontal, this is why it's important to follow the guidance. So if I go back to the this document, this is where you use that framework where it shows that on the first course you don't need to. The detailed pocket charting only comes when the patient is engaging. So hopefully that answers that question. So you use the guidance and the information that's been provided by British Society of Periodontology and Implant Dentistry. They provide that information for you. Moving on. So hopefully that's given you an idea. So if I go back again, now that's just one perio case, and that was a very complex case. And again, I gave it a go. The point is you give it a go. You're not going to win everything. You're not going to win everybody over. The point really is you try, because if you don't try, what's going to happen to this patient? He's going to lose all his teeth. But at the same point, what the outcome of that patient was that he went on for specialist care. But you will not be accepted for specialist care until you've actually had a go at this first. And this is the issue, that you've got to have a go. And at the same time, if you follow this protocol, follow the guidance written down in the avoidance of doubt document, and also the information that's provided by the British Society of Periodontology. And it's Ian Chappell who's done a lot of this work in the background. And he did, I've listened to him speak a few times now, and he did a great talk. A couple of times now I've listened to him, and the last one just only a few months ago, and it was fabulous. It was very inspiring, and he goes on to explain again and again that you can make it work in the NHS. There are ways of doing it, but at the end of the day, you've got to know your limits. You know when you can succeed, you know what you can't, when you know that you're not getting anywhere, and at that point then you refer on for specialist care. Next patient. So this is a patient who I saw not that long ago, actually. This is only going back maybe a month or two ago. So this is a 15-year-old young girl. Now, if you look at that, you can see poor diet. Again, no particular relevant medical history, but high caries, energy drinks, very occasional brushing. This is somebody who I mentioned right at the beginning. I do a lot of ortho. This is somebody who's referred to me for braces. Can you imagine with teeth like this? as far as I'm aware, and I remember reading the referral at the time, no mention that there was a big hole in the lower left six. The fact there's a periapical lesion around the lower left six, there's a buccal swelling there. Now, obviously, this is not, she was not going to get braces anytime soon. A number of carious lesions to treat. Look at the photos, you can see there as well. Lots of things going on. You can almost see the teeth rotting in front of you. It's, you know, it's that sort of wet caries, red swollen gums, more perhaps diet than oral hygiene issues here, but certainly it's a combination of lots of things. The issue really here is the fact that before even thinking about braces, you've got to sort this patient out. Number of things going wrong all at the same time. 15-year-old. Now, one of the benefits of that is that, again, you don't have to worry about patient paying at this age. They're not going to pay. But what you want to try and do is, again, phase that course of treatment. There's no point diving in, saving this patient if, you know, they're going to end up with rotten teeth anyway. You've got to sort the preventive bit out first. You've got to sort out the oral hygiene. You've got to sort out the diet first before you do anything else. So what happened? So this is another colleague within my practice who did this, but essentially the idea is the same. The first bit, again, urgent band, 1.2. Extirpate, dress, get the patient out of pain. The main problem here was that lower left six. Get them out of pain, sort that out. Wasn't difficult because all it really needed was scooping out all the caries and dressing the tooth and making sure they were out of pain. And that was important because that was her main concern. Then you reassess that patient. Then you do the full exam, BPE, radiographs, oral hygiene, TBI, all the stuff you're supposed to do, the PMPR. This is where you talk about phase course of treatment. You tell the patient right at the beginning. Then you restore those teeth that you can restore. But again, only making sure that the patient is fully aware that this will not work if they don't change their diet, they don't sort their toothbrushing out. Very important. So this is done, as you can see, multiple carious lesions, band 2B, 5 UDAs. See them back 3 months later and you reevaluate. You check the oral hygiene, you do the TBI, do the education. At this point, yes, you look at that patient and say, yes, it's possible now. We're getting somewhere. We've got an engaging patient. That's when you provide when the endodontics was provided to that lower left six, band 2C. Again, couple of appointments. Then you see them 3 months later, reevaluate, take a radiograph of that six, make sure it's done properly, checking again the UHI, TBI, educate. This point was then the crown was fitted to that lower left six, again over 2 appointments. Maintenance phase, see the patient 3 months later. At this point then, you know that the patient is engaging, or fortunately this patient was engaging. Making sure the oral hygiene completely changed. The diet completely changed. You could actually see the improvement just by looking at the teeth. Teeth just looked better. The gums looked pink, not red and swollen. And at that point then, the patient was then assessed for orthodontic treatment moving forward. But again, look, it's over a long period of time. Staging the courses of treatment. Telling the patient right at the beginning, you're going to be coming to see me for a while. We're going to do this in bits because at the end of the day, you've provided the best care for that patient. Yes, it's a lot of work. Yes, it's a lot of time spent on it. But the outcome was worth it because then she went on to have that orthodontic treatment that she initially came for. And that was the important bit here, making sure you provide that care. And hopefully, when you get a patient like this, you're providing that care. This is something they're going to then live with and then hopefully continue on having that good oral hygiene, good diet for the rest of their lives. That's what you're trying to do. And of course, following on through orthodontic treatment as well. Then we talk about this chappie. So hopefully, as a little summary to that one, you can see again, what I want to try and say is, again, you see this patient walk in the door. And I remember 2 or 3, 4, 5 years ago, my heart would sink again. You see this patient, you think, crikey, I've got to do all this work. And I can tell you straight away, I know a number of people who would have taken a pair of pliers to that 6 and taken it out. Now, in this particular patient, the way the orthodontic treatment was going to be, I did not want to lose that lower 6. If we could hang on to it, and I know we talk about, removing 6s at the right time, but as you can see in this patient, she was 15. This was not the right time to lose those 6s anyway, because it would have been almost impossible to close any spaces. So what you want to try and do is trying to hang on to as many teeth as possible. You want to try and do the best you can for that patient. Now, if you saw this patient at the right time, yeah, you could imagine that that point, removing some of those teeth would have been perhaps the best course of option, because that would allow the 7s to drift forward. But at 15, that was not going to happen. So again, providing that extra level of care, phasing the treatment, best interest of the patient, providing the best care, going back to those first principles. And again, it's a good result at the end of it, but worth your while at the same time. So anyway, moving on to this one. So this chappie, 51-year-old, epileptic, on lots of medication, poor diet, collapsing dentition. So it's a new patient to the practice, not seen him before. Very average oral hygiene, high sugar diet, had a habit of sucking sweets all the time. And I think that's partly to do with his epilepsy. I'm not quite sure. I mean, I did ask him what the issues were, but he was a bit vague on that. As you can see, is missing a load of back molar teeth, struggling eating. All the biting and chewing is being done on his front teeth. If you look at his front teeth, the front teeth aren't that great either. He's got a bonded bridge in place. Again, look at the caries. Look at the photos. At this point, when I took the photographs, he'd lost that lower 6 crown already. Fortunately, no pain. That crown's dropped out already. You could see from the previous photo, it wasn't far off coming out anyway, let's be honest. But it'd gone. Fortunately, because he's in no pain, it was a relatively straightforward. There was no urgency here, but he needed proper management, proper care. And the bit I was worried about was he'd already lost that upper right one. I didn't really want him to lose any more teeth. We were trying to hang on to these teeth as much as possible and trying to give him some more teeth to chew on to try here. But he needed proper management, proper care. And the bit I was worried about was he'd already lost that upper right one. I didn't really want him to lose any more teeth. We were trying to hang on to these teeth as much as possible and trying to give him some more teeth to chew on to try and support the anterior dentition so that he wasn't going to lose any more of his teeth. So what did we do? So phase 1, again, there's no urgent treatment here. Straight in, full exam, BPEs, radiographs, oral hygiene, all the stuff you would do. Tell him straight at the beginning, pain patient, no problems there. Tell him this is going to be a phased course of treatment because we've got to do everything in little bits. So we restored the teeth that needed to be restored. That lower left 6, that was coming out. It was subgingival, the caries, even root filling. You're not going to be able to restore it to any sort of meaningful prognosis anyway. So took it out, a couple of appointments, done in 2 visits, 1 side at a time, band 2B. 3 months later, you reevaluate. OHI, TBI, you educate the patient, look at him again, see what can be done, change his ways. Suddenly he was not sucking sweets anymore. He wasn't drinking energy drinks. He had a habit of drinking lots of energy drinks as well, which again, something you can see he's got a fair bit of erosion on some of his teeth as well, partly down to the fact that he hadn't got many back molar teeth and all the chewing was getting done there, but he wasn't helping himself with his diet either. So at this point, yeah, he's obviously changed, he's modified his diet, things are getting better, his oral hygiene is improving. So at that point, then you think about more definitive treatment, we talk about dentures. So we're trying to support his anterior dentition by providing him with some dentures. Then you reevaluate 3 months later, again, making sure everything's okay, making sure everything's settled in. You notice there was a bit of staining on the upper right too. That had got a little bit worse, and it was I was concerned because this was an abutment for the bonded bridge, so we did that as a composite restoration at that point. So just a straightforward restoration, did that as a band 2A. Total treatment time about 9 to 12 months. UDAs and the remuneration. And at this point then, you've got this patient stable. You've got this patient who is happy, he's got good teeth, he's looking after himself, his oral hygiene is changed, he's managing himself much better. We had a conversation about his medication, so he had a chat with his GP, and he's able to manage his medication and change some of the dosages from his medication as well. Because I think one of the things that was happening was he was on such a lot of medication, he was actually finding he was feeling dozy quite a lot, and he just wasn't looking after himself. It's a bit unkempt, but that changed as well suddenly. And this is what I mean about, it was almost life-changing for this patient. He's a totally different person when he'd come and see me, 9 months later. Looked different, looked like he'd been looking after himself. His teeth looked better, he looked better, he felt better, his mental health was much better. And these are the side issues, the plus points coming from managing these people properly, providing that phased level of care, not just trying to do everything all in one go. I know if I'd seen this patient, 2 or 3, 4, 5 years ago, I would have done that all in one band. The dentures, the restorations, the extractions, everything would have been done in one go. But phasing this treatment now, one, he's looking after himself better, but two, that you're providing this patient with much better long-term restorations and prostheses that are much more likely to be successful. And again, now he's looking at having perhaps a replacement bridge for that upper right one. It does look a bit unsightly, and that's something we can discuss next time we see him. So we talk about, why is the avoidance of doubt, this documentation, why is it underused? I mean, this has been around a few years now, say 2019 with a revision in 2021. So why do not more people doing this? And I've been doing it for a while, and I find it's really useful. And again, using it correctly, using the protocols, not for everybody, again, making sure you use it for the right patients in the right cases at the right time. The only thing I think of is, one, people don't know that exists. So hopefully one of the joys of hopefully coming to talk to so many of you today is actually just to highlight that this document exists, highlight that this is possible, things you can do legitimately within the current regulations. Perhaps you don't know how to implement it in practice. Hopefully I've given you some ideas. I've given you some worked examples. These are patients that I've seen have been treated in high street dental practices properly, correctly, and at the same time, I feel like I haven't, lost out either. The patients have been provided the best care. At the same time, I feel like that I've been remunerated properly and have provided the best care for the patient at the same time. So it is possible. It's just knowing how to do it, and treatment sequencing, properly staging the treatment, phasing the course of treatment, put it in the record, making sure you document it, justifying it. You're worried that the NHS BSA or the ICSs now, the ICBs, are monitoring. Yeah, absolutely they are. And they have done for years, and they will continue to. That's the point of record keeping, writing it into the notes, justify your decisions. If you can justify it, there's no reason why. You're doing the best thing for the patient at the end of the day. And I come back again. Don't think about the money. Remember what I said right at the beginning. The Tonyism. Get your dentistry right first. Money will follow. Don't worry about the money. Do the right thing for the patient. Think what's right for the patient. Just do that. Money will follow. So again, if you're worried about people going to come back, as long as it's all written down, justified, you should not have any problems at all. Just make sure you justify your decisions and provide with the FP17 DCs correctly as well. You're worried that the patients will not follow through. Personally, I say I've been doing this a long time. I've had a very low dropout rate. You know, once you start on this path and you see these phase course of treatment, you're worried that, okay, I've done this treatment now. I'm not going to get my 12 UDAs because they're not going to come back for that crown, or they're not going to come back for that denture, or whatever it might be. But actually, once the patient's engaged, you get buy-in from the patient. The patients realize that's in their best interests. That if they do this in a phase course treatment, one, it's going to be best for them, but two, it's also going to provide them with a really good set of teeth and really good long-term restorations, as well as prostheses as well, that will then last them for years and years and years to come. Not 6 months, every 6 months there's something else gone rotten or something else has dropped out. And that you get into that cycle of providing patients with fillings, and 6 months later, another 2 fillings, 6 months later, another 2 fillings. And I'm sure you know patients that you've treated and you've seen that are like that, that you know every time they come, they're just going to have another hole. They're just going to have more rotten teeth. But it's having that conversation right at the beginning, providing them. And you can't win them all. And I say that again. You cannot see that every single patient is going to be able to do this. It's going to be for those patients who are engaged and who are willing to change their behaviors and be able to look after their teeth, look after themselves as well. You're worried about the cost of the patients. Be honest and upfront and make no promises. I'm very honest with my patients. I do not have a problem talking about money. I don't have a problem about saying this will be phased. You'll be paying a band 2 every 3-6 months, whatever it might be, every few months. Tell the patient right up front, it's going to be phased, but that's in the best interests of them and their teeth. Patients realize that, and it's not a problem. So if you're worried that patients aren't going to pay, actually, generally speaking, I've not had that in my experience. It does not happen. People are quite happy. And again, you're not going to do this for everybody. It's not for every patient. These are for those patients who need that high level of care. Provide them with that care, stage it correctly. I think the last one is a little bit more tricky because not every dentist will have the technical ability or will have lack of specialist knowledge to deliver that care. So this is training experience. Now, this is soft skills. This is mainly soft skills as well as some technical ability as well. But it comes with experience. This is what I was talking about, newly qualified, so FDs, and I've been a trainer for many years, and I know there are trainers on the course here as well, listening, will attest to the fact that when students come out, they're not taught very well to be able to talk to patients. They have the knowledge, but not how to then implement it properly onto a patient. That comes with time. That's a really hard one to teach because you just have to do it. Some people are very, very good at it. Some people aren't. But it's having that ability to be able to talk to the patient, but then not just talk, but walk the walk as well. Walk the talk, walk the talk. A lot of people will say all these things, I can do this, but when you actually do it, they're not able to deliver that level of care. And that again will come with time. That will come with experience. Slowly, baby steps, and you'll get there. So in conclusion, I think we've done pretty well for time, so we're doing all right. Hopefully by implementing some of these things I've said. Now, efficient treatment planning, again, it's about improving patient care, reducing waiting times, using your time more efficiently, and making better use of the resources that we currently have within the NHS dental profession. We can all win. The patients can win. You can win. And this is a Gandhi quote. Be the change you want to see. I love this quote. I use this quite a lot. You have to be that role model for others to follow. It only takes one person to get the ball rolling. if you're working within a multi-surgery practice, be that one person. Other people are going to come on and follow, and hopefully they will then be able to implement some of the things that you're doing as well. And I do this in my practice as well, where I have some associates who then see how I do things, and then they sort of do it that way. Using this document it's a no-brainer. It's a win-win. The patient gets good care, and you are going back to first principles, doing dentistry how you were taught, but also getting remunerated for it as well, and being able to fulfill your contract. Thank you for listening. Much appreciated. Hopefully that has given everybody a little bit of an idea of what we talk about when we talk about efficient treatment planning and phasing course of treatment. At this point, I will open it up to the floor. Now, if you have any questions, I know I've been answering some of the questions as I've gone along, but I point out again, a lot of this is stuff that's in the public domain. People just not aware of it. Look at the document, read it. Those of you that have my LDN app, it's on the app as well. Please look at it. It's available online. You just have to Google it. The other documentation that's been put up, I know there's been links been put in the chat, and thank you very much for the people who put that up. Really appreciate that. I am no expert. Okay, I'm just a dentist here, right? And I say this every time. I'm just a dentist. It's just experience and time, and being able to use some of my experience and time to provide the best care I can within the NHS. And I've always been an advocate for the NHS, and it's harder and harder these days, I think, to be able to provide really good care for dentistry. But this is one of the things I think that really was a bit of a game changer. This, and also the staging, the way they've split out band 2 into 2A, 2B, 2C. I think that was a really good move as well for the Department of Health, because what it's done is it allowed people then to be remunerated properly for higher needs patients, that people need that extra level of care. And hopefully in the future, people will find that more and more people who do utilize this protocol are able to utilize it properly and be able to provide and deliver care properly. And again, I've put on there the QR code for those people who want to sign up for the VLE, the new virtual learning environment that WT, Working Training and Education, BIT, what used to be called HE in NHS England. Please use your cameras, use the QR code, go to the website and register for that environment. They've started to put some courses and some teaching materials on there already, and it is going to be, I think, a really good portal. I know we've been using Accent for many years, and I've never been a very good advocate of Accent, I'll be perfectly honest. I always find it a little bit cumbersome and a bit slow. Trying to scroll through it can take an age sometimes. And I think the fact that they're putting this together, this VLE, it's a great move forward for WTE, and I recommend it to everybody. So I'm going to finish there. Questions. So if you have any questions, or have I just sort of blasted you with everything that all you need to know and everything is there? But actually, a lot of the information I've told you is stuff that's out there. You can search it, you can Google it. But if you have any burning issues or questions, stick them in the chat, and I'll give it a go. But otherwise, I bid you a very good evening. Thank you very much for coming. Thank you for such a great turnout. I hope it was useful. I hope it was informative. I've tried to be as honest and upfront as much as I can. And again, I've used real world examples of patients that I've treated, been treated within the practice, to demonstrate what can be achieved within the NHS and within the current guidelines and regulations. Thank you. I'll wait for some questions if there are any, but if not, I will bid you a very good evening. Thank you all very much. And I've given you a few minutes back anyway of your time. Enjoy the hurricane, and looking out of it through the window at the moment. It's blowing a gale where I am. I don't know about you, but it's supposed to be quite blowy at the moment. But I can't see any questions. Oh, there we go. There's one come up there. Did you do a follow-up for those ones? Oh, right, crikey, you want me to do a bit of teaching? uh, right. I could always do a follow-up course if you want to bring some cases and we can chat through. Yeah, absolutely. I think that's down to the powers that be at WT want me to, if they want me to sit down and do some treatment planning coordination sessions. If you want to bring some cases, more than happy to chat through those. Perhaps we'll have a chat about this offline, and perhaps have a chat with who was it? Is it Jenny? Jenny Ross? Oh, I think she's on the call somewhere. I'm sure I've seen her name somewhere.
I am Tony.
Oh, there you are. Right. So if she really wants me to run another one where we talk through courses, more than happy to. I'll leave it with you, Jenny.
Yeah, that's fine. We can talk about it. More than happy to support it, though, if people want, if that would be helpful.
Thank you. And there's another question there. What if you have a high needs patient, 10 plus fillings based on x-rays? Do you do it in one course of treatment? Again, you're doing what's best for the patient. Now, I've sort of talked through some patients there that need multiple restorations over in one course. These are going to be patients that you're not going to see very often. Let's put it like that. If you have a patient that needs sort of 7 or 8, 9, 10 fillings, I think you've got to work out why they're getting all these fillings first. I think it's that going back to that prevention thing, making sure you get the oral hygiene prevention bit right first, and then there's absolutely no reason why you can't stage that treatment. You justify the treatment. If you've got somebody with that many fillings, they're not necessarily going to need that they may well need some other treatment as well. So we talk about, crowns and bridges and dentures as well. If you're going to do 10 fillings in one course, there's no reason why maybe 1 or 2 of those fillings may then need crowning in 3 months' time. This is how you stage that treatment. This is how you can then make it worth your while. Not going to be true for everybody. And I'm not saying that's what you do. What I'm saying is there are patients out there that you can stage, you can phase that treatment, look at them and treatment plan them almost every 3 months. You look at them and you say, right, I've done this bit. Now what do I do next? And almost every 3 months when you see them, they will have something else or something's changed. You can't sort of stipulate exactly what's going to happen every time. You've got to treat that patient what in their best interest. And I can't say any more than that, really. So there's another question there about stabilization, and also if a patient comes in wants dentures as a chief need. I think you got to go back to first principles again there. I think is it Ranjana Aurora has mentioned that one. What's in the best interest of the patient? You provide the care that you think is best for that patient. Now, if you think that providing dentures is the most important thing for that patient, then fine, do that bit first. It's very hard for me to answer that question because it will depend on what is the most important thing for that patient to provide at that time. Then you have to think to yourself, if you've got rampant caries, if you've got perio teeth, is actually providing dentures the best thing for that patient? And I think that's only a justification that you can make, and that you can have that conversation with that patient, who will then be able to then make a joint informed consent treatment plan. But yeah, there are occasions when you see somebody, if he's lost his front teeth, one of the first things you do is provide him with a denture to sort his front teeth out, and then go on and carry on with the rest of the treatment in phases and stages. There's no problem with that. There's a question there about contacting your local LDC. Absolutely. If there are some issues, individual cases, local dental LDCs are very good at providing help and support. Oh, a big plug for peer review. Yes, please. Thank you, Samia. I'm a big advocate of peer review and have been for many years. And we have a number of peer review groups locally in Shropshire and Staffordshire. I can only advocate that. This is a great way. And you talked about talking about complex cases. Peer review is a great way of doing that, where you have, lots of minds, lots of heads, all talking about the same thing, talking about the regulations. There'll be something that somebody else thinks of that you might not think of, and having that conversation about those more complex cases with your peers, I think, is a great way forward. So there's another question here by Zarmina. New to the NHS. So in urgent band 2. Okay, you're talking about regulations there around banding. I think there's a link being put in the document. Thank you very much. I think it was Thomas O'Connor who put in a link there about after an urgent band, what you can and can't do. So if you have a look on the link there, it's in the chat. That may provide you with some information. Good communication courses, lots of them. Look at the accent. That's the first one. And the VLE, I think, will start producing more of this information and more of this support and information. But I come back to communication. I think one comes with practice and time. Very hard to teach this. You just got to do it. And the more experienced you are, the better you get at it. But peer review. Come back to peer review. I think is a great way of talking amongst your peers, talking to other like-minded professionals who will be able to give you that support. I find, actually, I don't know if it's harder to do if you have a smaller team, but if you've got a few dentists, so in our team meetings that we have at work, at the practice, any sort of complex cases that the other dentists have, they're quite happy to bring those into team meetings and we can talk about it. But if you're single-handed or don't have other people around you, peer review is the best way. And talking to other like-minded professionals, that's the best way of getting better at talking to patients, how you say things, and providing the best information or ways of talking to patients. Often is how you say things. It's not so much what you say, it's how you say it often is the most important thing. Thank you, Kate, for the CPD bit. That's fabulous. I think Jenny Ross put it. Oh, thank you. Yes, yeah. There's lots of regular courses on NHS rules and regs. Thank you for that. That's fabulous. Is there a 3-month minimum open to new course of treatment patients? Can therapists have? Yes, they can. Absolutely. The peer review is open for therapists as well. There's no problem with that. And the funding is there for peer review for therapists as well. I was very clear about that very early on, and it's in the document as well. Is it 3 months the minimum time to open a new course treatment after they approve? I believe it is under the current regulations. I think that is correct, if I'm not mistaken. But again, if you look at, and I think that's made clear in the perio bit of the document as well, that it's 3 months recalls. With the perio patient who's not motivated to stop smoking, how do we then stage treatments? I think if you go back to that document that I talked about, where it gives you the staging of perio treatments, what you're talking about there is a non-engaging patient then, and there comes a point where you're just providing palliative care then. So if you know you're not getting anywhere and the perio is not improving and they're not willing to change, then you're just providing support and palliative care to that patient. And I think that's it. Fabulous. Thank you very much. And if there's no more questions, well, thank you very much for your time. Thank you for the help and support. Thank you very much to Kate for being in the background. Thank you very much for Jenny to providing me with this opportunity to talk to my esteemed colleagues around me here as well. And I hope that's been useful and helpful for some of you at least. And at the same time, providing you with everybody with some important framework and some templates and protocols for you to be able to deliver the best quality NHS dental care to your patients, again, in the right way, at the right time, with the right materials. There's no reason why you can't provide good care for high needs and vulnerable patients within NHS dental practice. Not for everybody again, but it is a way of doing it, and hopefully this will provide you with that framework. Thank you very much. Have a lovely evening. I'm going to sign out now. Goodbye.
Thank you, Tony.
Pleasure.
Thank you.
Cheers, Tony. Bye.